Well, hey everyone, I'm going to give you a little hacking performance tip. This one comes from the relationship between the gut, the viscera, and your neck, and also your shoulder. And it's important for overhead athletes like volleyball, tennis, baseball pitching, even Australian rules football, where there's a lot of catching of a football, which we call marking, overhead. So I want to show you something here. Let's say I'm sitting down here in my home office, and if I was to lean my head back, have a little bit of a look at how far I can lean my head back if I sit slumped. So I'm slumped now, and I look back. It's not particularly high, right? So let's look at it from the side. So I'm slumped, and I look back. And that's about the range of motion I've got. Here's the thing. You're supposed to have about 80 degrees of cervical extension. So if my hand represents the vertical, and you can see my cat in the background, but that's okay. My hand represents the vertical there. So it should go back approximately, that would be 90 degrees, so approximately 80 degrees. Now, if I'm slumped, that's how far I can go back. If I then sit back up, bear in mind that I don't have a full 80 degrees normally. But what's the difference between slumped and vertical? So you can clearly see there's a significant difference between the two positions. Now, the only thing that's changed between those two is thorax from a flexed position to thorax to a neutral position. So that brings into play this concept of regional interdependence, which means that impairments in some parts of the body, which seemingly are not related to the area that we're interested in, the neck, can actually interfere with the neck's function. So an impairment in the part of the body such as the thorax, and the impairment being the inability to extend to a neutral position, okay, can interfere with the neck's ability to move. And that's important if you're an overhead athlete, because a lot of the time the ball that you're playing with goes overhead, right? So you need to get your head up, like so. Think also about a time trial cyclist, or even just a road cyclist, who needs to have the ability to go into a trunk flexed position or a hip flexed position. So maybe the trunk is relatively stable and secure or neutral, but they're flexed over at the hips for the bike position. So then, of course, you've got to look forward towards the road. So you need cervical extension to be able to do that. So those individuals who are playing overhead sports, whether it's cycling or volleyball or tennis, Australian rules football, who are getting neck soreness, don't discount the possibility that part of their restriction to being able to look overhead, which you should do an assessment of by having them stand and do a cervical extension and look for 80 degrees of movement. Don't discount the possibility that you've got an issue coming further down. Okay. Similar with shoulder. So if I was to try to raise my shoulder forward, so I'm going to start in the slumped position. That's me really working hard to get my range up. Now I'm going to sit up taller, and all of a sudden the shoulder raises up further. So when you have an individual who's struggling to get an arm overhead for spiking, for racket shots, or for catching a ball, then you've got the possibility that the reason that shoulder's not getting far enough overhead is related to that trunk not being able to extend enough to neutral, or even in extreme circumstances to go beyond neutral into extension. Sorry, I shouldn't say extreme circumstances, because it's not extreme to be able to extend past neutral. So here's another little hacking tip. Don't discount the possibility that the inability to extend at the thorax is related to the viscera. And I want to teach you something here. Let's say that, for example, you've got a neck which has lost cervical extension as measured by a physiological active movement. And then you do a passive physiological movement, and you also find that, hang on a minute, this neck can't extend to 80 degrees. So then you decide, okay, I need to do a local biomechanical examination, and that involves doing some accessory mobility checks to see whether individual components of the cervical spine can side flex, can rotate at each segment, can do anterior to posterior shears, and can distract or compress. Okay, so these are subtle feels that you should be doing. Now that's what we would call a dynamic assessment, where you actually hold a segment stable and then you move another segment, or you hold a segment stable and you move another segment. But before you even get to dynamic palpation assessment, meaning moving assessment of accessory motions, why wouldn't you go back and do a static palpation assessment? Well, you should, because when you do a static palpation assessment, one of the things you're looking for is the presence of any deformities and heat in particular areas, which might indicate that you've got something going on that you need to pay attention to, or even changes to the normal contours. And so we might start with sort of broad interactions and then refine our contact to local finger points. So I want to simplify it even further. Let's say that you have a person laying supine and you place your fingers behind the spinous process. Okay, so I'm effectively cradling that person's head and then I'm using my fingertips to move along the cervical spine. And I'm looking for the spinous process because that just simply tells me where I am. I'm in the midline. So then I take my fingers in the midline and I move them just a little bit laterally. And then I can depress my finger from a posterior to anterior direction through the tissue, like so. I'm not intending to deform the tissue. I'm intending to assess to what extent can I deform the tissue. Let me give you an example. On my right-hand side, I attempt to deform the tissue and my finger can move that far. On my left-hand side, I attempt to deform the tissue and it can only move that far. Well, what's stopping me from being able to do that? And the answer is that I'm paying attention to how much resistance is coming against my finger. So in the early stages of you depressing the first few layers of skin, subcutaneous fat, there's a fair bit of give. Your finger can actually move through without a great deal of resistance. And then you take up some of the softness of the paraspinal muscles. And as they start to compress, it becomes more dense. And at some point in time, you have to make a decision that says, I have to push a little harder now. For the first few millimeters, I'm not particularly pushing a great deal, or half a centimeter. But on the opposite side, it tends to be a resistance much earlier. It's really common in the physical therapy curriculum. In fact, it's actually not that common anymore as far as I'm concerned. But in the past, it may have been said, oh, you've got muscle tone there, so we better just massage your muscle or do a dry needling technique to reduce the tone of that trigger point. Because the reason that you have got that difference is because of muscle bulk. You've got hypertrophy, or you have atrophy on the other side, or you have, for some unknown reason, some neurophysiological tone. Okay, I want to bring into concept the possibility of something else. What if that particular segment has got a rotation to it? And so as it rotates, what happens is that the paraspinal muscle on that left-hand side is now moved downwards because the articular pillar on that left-hand side is rotated towards. So it's pushed everything down towards the surface of the skin. And on the opposite side, on the right-hand side, that articular pillar is rotated a little bit, which means that you've now got more space to depress that finger into. So let's go back a step. I'm in the midline, and then I go paraspinal, and then I depress and I depress. And I'm paying attention. I often go closed eyes because that means I can direct all my sensory feedback to the fingertips. So then you're detecting at what point do I feel a resistance. Now, it's actually quite reliable when you get a room full of people that don't have a great deal of training, and you just sit them down on the neck and go to that point and walk them through. And you go, can you feel a difference between the left and the right side? Take your hands off, step away. What does your gut instinct answer? And most of the time the people say, oh, I don't know. You say, rightio, we'll start again. And as you continue to do this and you soften the feeling, and you ask them to make a judgment call, there's a high reliability between the individual raters about what they're feeling. Often they can feel a small difference between one side versus another side. So then you have the circumstance where your static palpation assessment, or your SPA, has demonstrated a segmental rotation. Question: do you think that static palpation assessment revelation, what it's revealed, might interfere with the cervical extension that we were talking about for overhead athletes? And the answer is, it's on the possible list. It possibly could interfere with it. Don't jump ahead to treatment, because there are possibilities where you might say, massage it, dry needle it, manipulate that segment. And I would say, wait a second. Don't forget this concept of regional interdependence. What if that segment that's rotated is behaving in that particular way, but it's not its fault? It didn't suddenly decide to rotate. Maybe it's behaving in that particular way because of something going on elsewhere. Now, there's a whole range of possibilities as to what would cause that, but I want to talk to you about that visceral element that I mentioned at the start of the video. If that segment, let's call it C3, okay? C3 is rotated on C4. And let's say that it's rotated to my left. Okay, so the right-hand side, remember the person's laying supine, the face up. The right-hand side is in that direction, left-hand side is down. So in everything, it's turned to the left. Now, what if C4 on C5 is also rotated to the left? And what if C5 on C6 is also rotated left, and C6 on C7 and C7 on T1? You can see where I'm going with this. If you continue to follow it down through T1, T2, if you continue to follow it down, you may end up finding a particular segment which ceases to be rotated. Let's say, for example, T4 and T5 is quite neutral. Now, recognize that at some point you can't palpate all the way down to T2 and 3. You may need to turn them over. And so when you turn them over, notice that the right-hand side is now, it's over there. So you have to change your perception of what's depressed and what's elevated. But you follow it down and you recognize that at one segment it's now neutral. That's interesting. Remember that for a moment. But if you kept going, you might find that it's turned the other way. And so now you have a segment below T45 which is turned the other way. So now you've got a spine which is actually rotating at some point in one direction, and then at one particular segment it stops rotating, and then above that it rotates back the other way. That can be confusing as to why that would occur. Let's not delve into that too much. But you often find that it's that transition point that becomes painful. It's the one that's caught in between rotating segments beneath it and rotating segments above it. Now you're starting to see that why would we go ahead and treat C23 when possibly the reason for C23 behaving that way has got something to do with further down below. Okay, let's take a step back. What if all of the segments were rotated towards the left all the way down to approximately L1? Okay, so now I want to introduce you to the concept of what the viscera does. So your viscera being your abdominal organs, let's talk about the abdominal viscera. It's wrapped in a fold of mesenteric tissue, fascia. It's innervated and it's vascularized. And this fold wraps all the way around the small intestine and large intestine. Now, there's approximately 5 meters or so of small intestine, about a meter of large intestine. And then you've got a stomach and a liver and spleen and pancreas and gallbladder and bladder and uterus and ovaries. And there's a whole bunch of stuff down there. Let's not forget the prostate. But if you're talking about the sort of upper, middle, lower, right and left viscera, let's go small, large intestine, stomach, because they're kind of superficial to the front of the abdomen. Now, they're all wrapped in a particular fold of tissue, and that fold of tissue actually coalesces back at the L1 anterior lumbar spine, so level of about L1, and it's got its root attachment there. It's obviously got some strands that go a little bit above and a little bit below. From L1, it's also got a little bit of a slip of attachment down towards the right sacroiliac joint. All right, let's take a step back. You have a whole bunch of organs in the gut, wrapped in tissue, attached at L1, and if there is something going on in your abdominal viscera and it causes a tension or an increase in density, or there's a pain, what you may find is that because this myofascial, it's a smooth muscle, but it's still muscle, this myofascial wrap is responsive to the sensitivity of neural inputs of pain, tension, chemical exudate inside your intestines. It's entirely possible that your fascia will then behave and it may draw towards those sides. So if something is dense or tense, then it's going to draw and pull on that fascia. If it's dehydrated, you'll have the same kind of thing. So what may tend to happen is the fascia then draws towards the side of tension or density, and that it does so subconsciously. And this is a theory, okay? This is a hypothesis that I've been noting for several years, and it's quite consistent. It's hard to prove unless you cut somebody open and all of a sudden you've changed everything. So, in theory, you have a low L1 rotated towards the left, which means the right-hand side of L1 is pulled forward and the left-hand side of L1 is rotated back. And then T12 and T11 and T10 follow what L1 does, all the way up to C2 and C3. So why does L1 pull forward on the right-hand side and turn towards the left? The possibility is that you have an abdominal viscera, central midline or slightly right, which is sore, dense, tense, dehydrated. So one of the ways that you detect that is that you go ahead and palpate a fleshy part of the body, such as the calf or the medial thigh. Palpate that tissue and then pay attention to whether the person can tell you, does that feel like I'm simply pressing into flesh? Or does that feel sore? There's only going to be two answers to that. But if it's not sore, they'll say, oh, that just feels like you're pushing into tissue. Okay, so now you have a baseline for what normal pushing into flesh feels like. Just to be sure, do a second site, such as the medial thigh. So you do calf, medial thigh. Now, head up into the abdomen. We've hypothesized that on the right-hand side there's going to be a dysfunction of some sorts. So we'll go to the left-hand side and palpate approximately 3 centimeters, which is in the vicinity of the first interphalangeal joint, or the distal phalanx, for example. That's about 3 centimeters. So you depress your finger about that much. And the reason I say 3 centimeters is because that's skin, subcutaneous tissue, and approximately the thickness of your external oblique, internal oblique, transverse abdominis muscle. So if you depress through those first 3 layers and the person says, meh, that just feels like you're pressing into flesh, then you've got another baseline of the abdomen of what feels like normal. And what you've also determined is that you're not really having any dysfunction of the abdominal muscle in that area. So what you then do is you say, hey, okay, I would like you to tell me as I move around the abdomen whether what I'm doing feels like pressing into flesh or whether it feels different to that. Pressing into flesh or different. Is it sore? Is it sensitive? Is there a discomfort that's really different to pressing into flesh? Remember, calf, medial thigh, left viscera, left abdominal, anterior abdominal wall. Okay, so what you can then do is you can depress deeper through that first 3 centimeters on the left-hand side. And now you've started to depress any of the organs which are underneath, large intestine, small intestine. You won't get to the spleen on the left-hand side because it's tucked up underneath the rib cage. You may get to the ovaries if you went much more distal towards the pelvis. Okay, so let's stay sort of between pelvis and rib cage, and you're likely to hit large and small intestine on that left-hand side. And if you depress down through there, the person's going to tell you whether that feels like a stronger version of that pressure or whether it feels somewhat sensitive. Okay, you're starting to train your client to give you the right type of feedback to find the problem that might be related to their neck issue or their shoulder problem. So then you work your way around the anterior abdominal wall, usually for about 3 centimeters or so, or the distance of a distal phalanx. And then you depress even deeper again, and you start to pay attention to what areas of the visceral, the abdominal viscera, is feeling sensitive or sore relative to the other body parts that you've already checked. You start to form a picture, and it's a very, very common presentation that you're going to see the small intestine, say below the navel, or to the right-hand side of the navel, or superior to the navel, or even up into the duodenum, which is up towards the right-hand side of your rib cage margin, or even your stomach across the midline towards the left, or even your large intestine down that right-hand side between the pelvis and the rib cage. It's really common that you'll start to feel areas of sensitivity in those deeper sections of the viscera, more so than on the left-hand side. You can find restrictions and discomforts and sensitivities on the left-hand side, but you'll tend to find in the case example that I was saying, where you have a rotation to the left, that many more sensitivities will be over on that right-hand side. That brings us to the point of asking questions around, are you dehydrated? Do you have bowel symptoms such as loose bowel, bloating, discomfort, abdominal pain? Do you have any history of intestinal diseases, any abdominal surgeries where there may be some scarring? Do you have endometriosis in the female? And you start to piece some of these things together. Some of those diagnoses will be a medical diagnosis, and some of them will be a behavioral diagnosis, like irritable bowel syndrome is a behavior. And yes, it can lead to some changes that can be diagnosed endoscopically or colonoscopy versions. But a lot of them are behaviors. And if they're a behavior, then we can often change behaviors because that brings us to interact with the nervous system. And the nervous system is going to respond to being well hydrated. It's going to respond to diaphragmatic breathing. It's going to improve when we use touch in a way that's non-threatening. And so we have treatment options. And so I come to the end of this little video because the treatment options are for another time. But don't discount the possibility that you have a right side abdominal viscera issue which is pulling, or it's creating density, tension, dehydration, discomfort, and your L1 just behaves in a particular way and rotates towards that side. And that that behavior changes all the way up the chain towards that neck. And all of a sudden you don't have neck extension. Or because of the way that that's behaving, you get a person who prefers to be in trunk flexion to take some of the pressure off that viscera. Bear in mind that that visceral restriction can also impede lymphatic flow, and that lymphatic flow can manifest itself not just through that lower right-hand side abdominal viscera, but all the way through to stomach, even esophagus. So where does the esophagus attach? Anterior thorax, all the way through to the neck. So is it possible that your esophagus behavior is creating some reason for your mid-thorax and cervical spine to rotate towards that particular direction? Of course, it's possible. Is it easy to prove? Not really. But it's easy to confirm that it's possible by doing some kind of treatment to the viscera and then reassessing through your static palpation whether those segments have changed back to more of a neutral position. And if they change because of the work that you've done, you then follow it back up to the neck and you see that the neck is now a little bit neutral. So then you have the proof that says something we did in the viscera caused a change to the static palpation alignment of the thorax and cervical spine. That's all interesting, but it has to change function. So then you go back and you ask that person to do a cervical extension and you find out that lo and behold, not only do they move further, but they don't have the pain or they have significantly less pain. Now maybe they don't quite reach 80 degrees, but if they've improved, you've indicated the relationship between the anterior abdominal wall and the viscera. You've indicated the relationship between the anterior abdominal wall and viscera and the spine all the way through to the neck. And of course, go ahead and check that shoulder movement, because that's what we're here for, is to help this individual use their arms overhead and use their neck into extension so that they can get into the game, which allows them to execute their skill, which allows them to win the game, hopefully. So, wrapping all of those things up, we have the possibility that a visceral issue may interfere with cervical spine or shoulder. A shoulder problem ain't a shoulder problem by itself. A neck problem ain't a neck problem by itself. It is a representation that something's not quite right, and it is incumbent on us to evaluate the individual using concepts of regional interdependence and appropriate assessment. Now, that's for another video.